right. Thank you everyone for joining us this afternoon for EMS Council Workgroup and Ambulance Safety. Just a reminder that this meeting is being recorded and will be shared to the Bureau's website. So anything said or shared in the meeting, whether part of the discussion or in the chat, is part of the permanent recording that is shared on the ADHS's website. We just want to say a big thank you to all the members of EMS Council that are on the meeting today, and everyone who is here both virtually and in person for today's follow-up meeting. Is there anyone that want to do new introduction? We'll just open it up. Otherwise, we will move along with the meeting. All right. Thank you. If you can go ahead and bring up the slide deck, Shelley. Sure. Right, so we are going to go through a few slides. We'll definitely pause throughout the presentation. I would like to get feedback from the group and absolutely get input and see what everyone has to share with this. So just want to do a quick recap. We did share this at our EMS Council meeting last month, but a recap of the first meeting that we had on August 24th and some of the recommendations that came from this group. One of the recommendations specifically delineate minimum training requirements for ambulance operators. Make recommendations to decrease the number of code 3 or lights and sirens responses and transports. There was also discussion about public safety campaigns addressing safety around emergency vehicles, and then share resources for emergency vehicle operations training courses. So the goal that we're going to address today is really trying to kind of tackle those in a little bit more detail. And the first part, we would like to gather feedback on EMR training, minimum training requirements for ambulance operators, specifically looking at two components, one of which is the medical component and the second of which is driver's training. We'll get into some national components that help guide some of that discussion. The next part of the meeting, we'll look at discussing and approving safety messaging for National Crash Responder Week, which is in November. And as part of that discussion, we will review the national position statement on safe response modes for emergency vehicles, some opportunities for integrating safety into the system and balancing public perception, as well as public safety campaign addressing safety around emergency vehicles. So that will be kind of our goal today. So I wanted to share this infographic. This is a national infographic that I think really is very telling, that looks at ambulance crashes and safety throughout the United States. And it talks about from 2012 to 2018, looking at fatal ambulance crashes, the total number of crashes, the number of fatalities, and looking at kind of at some of the overall data. One of the key pieces when you look at the bottom right, which is really telling to me, is the percent that were not restrained of EMS clinicians. And this is something that we've really tried to address with some of the new technology. And one of the pieces that we definitely will cover today, as we see new things come into the system, especially the EMS 2050 or EMS agenda for the future, trying to address some of those things that we can implement to help improve safety, not only for our patients, our EMS providers, as well as the general public. So this is some ambulance crash data that was shared with us from ADOT. And I think this is just interesting data for us to look at. So this is ambulance crashes in 2022, the data from last year. And look at the total number of ambulance involved in motor vehicle crashes for the year. And that is approximately 56. So this is about 5% of our total registered ambulances in the state of Arizona were involved in an accident in 2022. So a pretty significant number. Fortunately, the number of fatalities is low, but it's still higher than we'd like to see. We'd like to see that number being a 0. But definitely wanted to recognize that we do have this data, and it's important to share some of that data with the community. Next slide. Thank you. The next is looking at a little broader ambulance crash data from ADOS. So this is 2015 to 2022, so over a longer period of time. And if you look at total number of crashes, which is the first column on the left, you see that there's 412 ambulance crashes that occurred during that time frame. And it's been pretty consistent when you look at the numbers. You see we had a slight drop in 2018, but outside of that, the numbers are pretty consistent year over year. We have approximately 1,000 ambulances registered in the state of Arizona. So when you look at those numbers, kind of based on that value, we're looking at about 40% of our registered ambulances may have been involved in a motor vehicle crash over that time frame. So again, really significant risk to our EMS providers, the patients that may be in that ambulance, as well as the So the next part we wanted to address was looking at the EMS Agenda 2050. So many of you may have heard of the EMS Agenda for the Future. They renamed the most recent version as EMS Agenda 2050. The interesting part for me when I reviewed some of this is really kind of understanding that we've implemented many of these things or have started to implement many of these things already across the EMS system. But one of the big goals for this for the EMS Agenda 2050 for the entire United States is looking at enhancing education model, standardizing training, national testing, as well as accreditation. And these recommendations come from several national organizations. So it's from NHTSA, which is National Highway Safety Administration, EMS for Children, which is part of HRSA, or the Health Resources and Services Administration, the Office of the Assistant Secretary of Preparedness for the Department of Health and Human Services, and Department of Homeland Security. So really from a federal perspective, the goal for EMS across the country is to really try to find a way to make things more standardized. We know that anytime you have a more standardized fashion of implementing things, you have better outcomes. So interesting when you look at a lot of the recommendations that came from that group. So specific to education and training, I thought this was interesting, very specific from the EMS Agenda 2050. And I included the exact quotes. On many of these slides, you'll see that the quotation at the bottom. So if you're interested, we will share these slides after the presentation. And you'll have those resources to be able to review. But they really talk about that when you look at training, that it should be a clinical education that includes realistic simulation and time and patient care settings. We recognize that during COVID, we had to transition a lot of our training away from in-person training. But what we found subsequently is that some of that training is not as good. As real as you can make a simulation, it's still not the same as actually doing training with an individual. They also focus on the importance of performing hands-on assessments and technical procedures, and develops critical communication skills while under the supervision of trained clinical educators. And I think that's the key piece. Many of us can think back to a point in time where we had some education that was provided to us, that was provided by someone who is maybe not a true educator. Comparing that to someone who you really feel this person is a great teacher. They know how to deliver a message in a way that kind of you can take in and then reproduce. The other key piece of the EMS Agenda 2050 was talking about national standards and certification to ensure consistent baseline education and competency for all levels of EMS personnel, to ensure that communities, employers, and the public, that every certified EMS professional is qualified and capable. So very specific language they included. So in regards to national standards for all levels of EMS providers, these have been developed in conjunction between NHTSA and the SEMSO and NREFTs. And SEMSO, for anyone who's not aware, is the National Association of State EMS Officials. And so there's several different parts to this, and I've included the links in the slide set as well. So there's the National EMS Education Standard. These were published in 2021. There's the National Scope of Practice that was at a comprehensive level updated in 2019. And then did have some additional changes made in response to the COVID pandemic. And those are really the most fundamental changes that were implemented in 2021. And the National Registry does have a number of national standards for all levels of EMS providers, and there is a link to the handbook for EMR as well. There's also been a number of testing enhancements that have been implemented or in the being implemented at a national level. And that's one of the things as a state that we do need to look at as well, as we see these new methods being implemented with the National Registry. How do we address and adapt to that at a statewide level? So what about the current EMR status in Arizona? So one of the things that was interesting to find out was there is an actual technical standards for EMR level, which is a very comprehensive description of the educational program. This is housed currently under the Arizona Department of Education. One of the things that are House Bill 2609 is that this goes into effect January 1st of 2024, but it does raise the bar above and beyond what that actual educational standard is. And there's very specific pieces that are included in that bill. And those are highlighted there. I apologize, the font is a little bit small. But it specifically said emergency medical responder program means this program that includes at least the following: the emergency vehicle driver training, cardiopulmonary resuscitation certification, AED training, training the use of non-invasive diagnostic devices, including blood glucose monitors and oximeters, and training and obtaining patient vital signs, including blood pressure, pulse, and respiratory rate. So one of the things that you don't see in many of this other curriculum is the driver's component, which certainly does get into some of the safety issues as well.
I'm sorry, the last sentence.
So this driver's training is not necessarily include a lot of the other national standards currently. So when we look at a proposal, when we want to consider the medical component of what do we think should be included in a medical component, one of the things we want to look at and see is how do we meet that requirement? So this is what's currently in that bill is going beyond what that's a national standard and saying, do we include at a 70-hour time at 70 hours to include both didactic instruction and practical skills training? We do want to recognize that there's the component of classroom time, but then you also need that hands-on time where you're developing that skill comfort level and assessment to be able to do those interventions. And then also including the minimum 5 contact hours to include clinical and field training, with at least 5 patient interactions. I was an EMT 20 plus years ago, and I still remember my very first clinical of taking a patient's blood pressure and having that interaction, and just keeping in mind that there's something very different doing that in an actual clinical encounter versus doing that in the classroom setting or on a mannequin. In regards to driver's training requirements, the first question that came up that we did discuss at the last meeting is, should there be a minimum training standard? We discussed emergency vehicle operations courses. Some departments said they had an abundant opportunity to put their personnel through EVOC courses. Other agencies said that this would be very cumbersome to find those. And then I did find it interesting. This was published in 2013, so it's already a decade old. But looking back at what came from the FEMSO, there was an ambulance driver best practices. And we'll go through a few slides of really highlighting some of the key things that they talked about. So they talked about defensive driving, SOPs and technology, as well as training requirements. In regards to the best practices, a big focus of this was defensive driving. And the more research you do in a lot of the articles that you read, this is the terminology you see mentioned by many individuals in response to ambulance safety. Is looking at the fact that an ambulance driver really must be effective as controlling their vehicle and driving environment in all situations and conditions, without compromising the safety of their patient, their partner in the patient compartment, or other road users. The skills needed to achieve this level of effectiveness are all under the concept of defensive driving. Defensive driving includes techniques of safe driving with awareness of the other driver's potential actions and intentions, as well as driving to avoid collisions and accidents and reduce the damage if accidents are unavoidable, regardless of the conditions and or actions of other drivers. Effective defensive driving requires ambulance drivers to be able to maintain awareness of blind spots, safely change lanes, and cross intersections, as well as maneuver the vehicle. It also states that ambulance drivers must be able to manage fatigue and other distractions while handling the ambulance in various weather conditions. So very specific recommendations that come from this. Kind of thinking back to 10 years ago, I think we know now with just cell phones and technology, there's a lot more distracted drivers than there were a decade ago. And certainly the ease of access and the number of people that have cell phones that use them texting on a regular basis, this is a huge source of distracted drivers, which certainly places all of our personnel and the public at risk. So the next piece in the national article is looking at best practices. So they talked about SOPs and technology, and they recognize that it's really important to have some type of standard operating procedures in the form of set rules or checklists. And they should address all procedures for acting in poor weather conditions when different. So we understand that here, if you're probably in the Phoenix or Tucson metro area, we've got pretty, stable, dry, sunny weather most of the year. But we do see anytime we do get rainy weather, and obviously other parts of the state that get snow and other kind of hail and ice conditions, a very different driving conditions. So what is your safety mechanism for that? How do you train individuals to drive in those scenarios? We recognize that because people aren't used to driving in those weather conditions, we probably have more crashes. So then we have more ambulances that may be responding. How do we train people to better respond safely in those scenarios? They also stated that ambulance drivers' performance can be significantly enhanced by the appropriate implementation of technology that supports situational awareness and encourages safe driving practices. However, technology can also be seen as a negative impact. So making sure it's not a distractor. I think, again, this is 10 years ago. If you think of your own vehicle, there's probably a lot of safety technology in your vehicle today that wasn't a standard a decade ago that you would have had to pay extra for, and now becomes a standard part of your vehicle and how you operate. And the last component from this document was really looking at training development. And what they talked about is that a training program is most effective when best practices are used to guide the developmental effort. If it's done well, this should maximize efficiency, safety, job satisfaction, and foster a culture of innovation. And they talked about best cultures to consider. One of those was training requirements. And this article felt that emergency vehicle operations course should be mandated for all drivers. Drivers should also complete supervised on-the-job training, with refresher training to be provided at least annually. Drivers should have multiple opportunities to learn and practice common driving maneuvers, such as braking, stopping, making lane changes, etc. And that these driving skills should be solidified by on-the-job training. They then get into course development, interactivity, and then refinement as a training course. So making sure that if you develop a course, that you review that course, update it as necessary. So one of the things we wanted to consider at this point is, what about future messaging for ambulance safety? There's certainly a concern about what is public perception versus safety risk. And there's been some interesting articles that have looked at this. And one of the things is trying to realize, how do we actually get this information? There's a position statement that was published last year, and it was published by 14 national EMS and fire organizations that was in the meeting attachment as well. And it's a joint position statement on life and fire and vehicle operations on emergency medical services response. And some of the key bullets are shared here. So they really said that all emergency vehicle operators should successfully complete a robust initial emergency vehicle driver training program. All operators should have required regular continuing education on emergency vehicle driving and appropriate lights and siren use. Again, recognizing you can't just train someone and say they're good for their career. You really want to make sure that people come in and get retrained on this. EMS and fire agency leaders should work to understand public perceptions and expectations regarding lights and siren use. And we'll get into a specific survey that was done that I think is interesting when you look at some of those factors. And then also they say that these leaders should work toward improving public education about the risk of lights and sirens to create safer expectations of the public and government officials. In most settings, lights, sirens, responsive transport saves less than a few minutes during emergency medical response. And there are few time-sensitive medical emergencies for an immediate intervention or treatment in those minutes is life-saving. And I think this is one of the key things, is recognizing there's absolutely time when we do need a light and siren response, where those 2 to 3 minutes are critical for patient survival. And we don't want to discourage that by any means. But we also want to recognize that we need to make sure that as we develop protocols, that we're really honing in on those scenarios. These time-sensitive emergencies can usually be identified through utilization of high-quality dispatcher call prioritization using approved D&D protocols. For many medical calls, a prompt response by EMS practitioners without lights and sirens provides high-quality patient care without the risk of lights and sirens-related crashes. And EMS care is part of a much broader spectrum of acute health care and efficiencies in the emergency department, which can compensate for those few minutes that are potentially lost. And so this is really one of the tenets that they looked at. So there's been more recently an article that was published by the 2 lead authors in the position statement paper, Kupas and Zavatsky, who really looked at in EMS1 publishing what they termed a culture shift, reducing lights and sirens vehicle operation. So some of this is kind of them leaning in a little bit more opinion-based, because this is in a separate article for the position statements, but they really focus on the 3 key things. And the key things they focus on are, what are some of the myths about lights and sirens response? So the first myth is that the community expects the lights and sirens response. The next one is that lights and sirens vehicle operation saves time. And thirdly, that EMS personnel enjoy lights and sirens vehicle operation. And really, when you look at this, especially at the last point, many EMS providers currently will already downgrade. They will read the dispatch information and recognize that based on time of day, road conditions, or the information that they've gathered from dispatch, that this call does not need the light sirens response. So many crews will already downgrade their response based on the information that they receive. Definitely, there's times where if it's rush hour traffic and it's going to take them a long time, that may be a scenario where if they aren't clear with what they get from dispatch, they may elect to still go in code 3 or lights and sirens. And so recognizing that, I think the last piece where the myth that EMS personnel enjoy this, I think most EMS providers, especially experienced EMS providers, recognize the risks associated, and when they're able to safely downgrade a call, will do so. So one of the key statements, and this was really phrasing a little bit more succinctly than I think the position statement stated, was what they're feeling is if a hospital staff does not perform a life-saving procedure immediately upon our arrival, then the life and siren's benefits did not outweigh the risk of life and siren's transport. When you think about time-sensitive emergencies, this kind of makes sense, right? If you have a trauma victim that needs an acute intervention, you have a STEMI, an out-of-hospital cardiac arrest, a drowning, someone who's choking, all these are clinical scenarios where those few minutes can be absolutely life-changing. And so you do have a risk-benefit analysis where the risk does outweigh the benefit. On average, life and sirens transport saves 2.4 minutes when driving to the hospital. And so you recognize that when you're going to a scene, the article states 2.5 minutes. This is based on a 2017 NHTSA report that looked at 15 studies. So they found that the time saved responding to a scene was 2.5 minutes, and the time saved going life and siren to a hospital was 2.4 minutes. So this 2 to 3 minute time frame, again, absolutely critical for certain conditions, and we want to make sure that we're still using that appropriately. We definitely don't want anyone thinking that we should get rid of life and siren response because those timeframes are critical. The other component they very clearly stated was that EMS agencies should perform quality assurance to determine if the benefit is worth the risk to the patient, the EMS crew, and the public. And this is something that was very clearly stated in the position paper as well, was the feeling that as an EMS agency, their medical director, the dispatch center should really be looking at their protocols to figure out when we get this information for this 911 call, is this someone that we should be sending a crew to, code 3 or life and siren, or this someone that we could safely do without life and siren response. So the next slide is really kind of looking at the culture shift. And I thought this was an interesting part of the article that they focused on really nicely, which is looking to see, how do people or the public perceive EMS riding without life and sirens? And many dispatch centers will tell you that people will call 911 and say, please don't have the unit use a life and sirens response, because they don't want everyone around them, their neighbors, knowing that the fire department or EMS is arriving to their home. So we recognize there's already a large segment that states we don't want a life and siren response. We want our medical emergency to be more private. In the 2017 report from NHTSA, they looked at 2 surveys that asked respondents about life and siren response. And the first one was from 2005 in Maryland. And Maryland was looking to decrease the number of times they spent units life and sirens to a scene as well as transports. But they wanted to survey the community because they were really concerned that the community would not be in favor of this. And what they found was that 85% of the surveyed public were comfortable with non-lights and sirens response based on dispatcher screening, and with non-lights and sirens transport after EMS evaluation. And that's a very sizable percentage. So if you look at this, they're saying if dispatchers are asking questions, they're pre-screening this call, 85% of the public felt comfortable with that being a non-licensed sirens response. And then once EMS is on scene and doing their evaluation, 85% felt comfortable with EMS making that determination of whether or not the patient needed a licensed sirens transport. So again, when we look at one of the perceived myths about what the public is wanting, this is something really important to consider as well. And then the one survey at the top, which is really asking have EMS agencies and crews do transport 911 call patients using lights and sirens, and you see here rarely it's 60%. So a much higher percent than I would have anticipated. Sometimes 31%, very often 8%, always only 3%. So again, you see this shift. I think many of us, when we think back to 20 years ago, this probably would have been very survey data that would have been obtained at that time. So back to the EMS Agenda 2050. So one of the things that I thought was interesting is to kind of look at this report. And this report was published in 2019, so it's already a few years old. But really, they were forecasting out through 2050. And what they're saying is that if people would benefit from being transported, they will be moved efficiently and safely using technology that minimizes the risk of injury to both patients and clinicians. The ambulance will not require lights and sirens, but will take advantage of other advances that expedite transit and prevent collisions. And responders no longer use lights and sirens to raise or transport patients. Instead, bystanders on scene initiate first aid using public access equipment and guided by real-time integration with medical telecommunications or other medical professionals. So when you first read this, you might think, well, this is kind of out there, but actually when you step back, we've already implemented many of these things. If you think about it, we have mechanical CPR devices. We have ways to be able to do these things more safely. We have naloxone and tourniquets out in the community. These things really weren't out there 5, 10, 15 years ago. These are things that the public can implement. We're trying to get more AEDs out there, and we do have more AEDs out there in the community that people can utilize and can help to respond to medical emergencies. We know that dispatcher-aided CPR saves lives. Arizona was one of the first states that really published that data as a Dr. Fabro. And we know that this is one of the key tenets of implementing a public health intervention to save lives. So many of these things can occur well before EMS arrives on scene. The other part that we've really started to change is our mindset of what we do on scene before we transport. So the next part of this, the EMS Agenda 2015, was that they stated EMS clinicians deliver time-sensitive and life-saving interventions on scene. This is key. If you think about the big training that we pushed in Arizona with the implementation initially of hand-holding CPR and CCR was stay on scene, do your resuscitation on scene. We found that these patients had improved chances of survival. And we've continued to see more and more data that comes out supporting this. If you look at the chance of the hospital getting rocked, if EMS doesn't get rocked, that's 0.69%. So my teaching to EMS crews is always, don't rush to get that cardiac arrest patient to the hospital. Stay on scene, do your good resuscitation, because you're much more likely to get return on spontaneous circulation if you stay on scene and perform that resuscitation. And we've definitely seen that with many other patients that are in what we term kind of a peri-arrest or close to cardiac arrest state for many other clinical conditions. We know that spending a couple extra minutes on scene to institute life-saving interventions and stabilize that patient will help prevent that patient deteriorating en route. When you're in the back of a moving ambulance, driving lights and sirens to a hospital, it's unsafe for everyone involved. But also, if that patient deteriorates, you're now trying to do those critical interventions in the back of a moving ambulance. So we recognize, while this is being pushed forward as, hey, let's look towards 2050, many of these things are actually already in place. Mechanical CPR is something that has really taken off over the last few years, with the focus being this is a way to safely transport that patient to the hospital. If you're now in a scenario that you're transporting this cardiac arrest patient, let's not have a crew unsecured in the back of a moving ambulance trying to perform chest compressions and transporting that patient to the hospital. So looking at towards Crash Responder Safety Week. So this is coming up in November, which is November 13th through 17th. And the theme for this is protecting those who protect you. And each day has a specific theme with the messaging to focus on this. But really looking to see, and this was one of the asks from the group, how can we support some of this messaging that goes out there? What are some different campaigns that we could support? We realize that already some of this work is being done, but can the EMS community also put out there and say, you know what, our personnel are a huge part of this picture. What do we support going out? Nice. I know this is quite small, but this looks at some of the activities that are scheduled for this with some hyperlinks as well. And then this slide is just showing a few different infographics that are out there, kind of looking to see what it's already out there in the community. So some of these I think are really good ways to demonstrate for people some safety. The top left you see from NHTSA, just reminding people how to move around vehicles, emergency vehicles that may be on a road, moving over, stopping for emergency vehicles. I like the one in the bottom right, see the light move to the right, finding it catchy, something to get people to think about this. Definitely we see the ADOT signs in the freeway that gets different branding to try to get people's attention, but those have been shown to really be effective. And what type of messaging does this group feel is effective? So I will close with that slide, and then kind of really we can open it up for conversation and discussion about all of these topics. I see Roy, your hands up. Go ahead, Roy. Maybe they have stars fixed on his phone.
You're on mute, Roy.
You know, for the next minutes, yeah, from Kyle. Yes, I can find that and send that out. The question in the chat for those who may not see that, can you make available the article about the percentage of patients that obtain rock the hospital when EMS does not obtain it in the field? Go ahead, David.
Hi. With my working with ADOT, with their crash records data, there's also the crash records report that gets filled out by law enforcement agencies across Arizona. When I asked the ADOT records director about identifying the percentages of ambulances involved crashes where the lights were on or off, said the only way we can do that is by querying each of the narratives of those crash reports that mention ambulance involved. Part of my working on the Traffic Records Coordinating Committee through the Governor's Office of Highway Safety is collaborating with updates to their crash report. Over the years, it's changed. We now have a new director at GHS, which is very EMS and public health supportive. If the group wouldn't mind, I'd like to have a conversation with the TRCC coordinators to see about adding specific check boxes and data that specifically identify whether ambulances, lights, and sirens were activated at the time of the crash, and other various data that's specific to the indicators like injuries, position, seatbelt use, etc., specific for ambulances, rather than having to look up each narrative. Because as you know, it's easier to query something if it's already a box that's checked versus trying to dig through narrative text. So that's a suggestion I'd like to pursue if you folks would agree to that.
Thank you, David. Roy, would you want to try this again? You are unmuted still. Shelley, just put the phone number in there if that helps. Vince, go ahead. I see your hand raised in the intro.
Yes, Dr. Bradley, I must say that was an excellent presentation. You took the key points about all of our discussions at the past meetings, and you put it in such a way that it was very organized and thoughtful. I appreciate it very much. Thank you. You know, for me, the biggest concern is, like you said in your presentation, you know, the safe response to a scene. And we use this response time of minutes to measure it when it should be something more, you know, focused on those cases that we do make a difference. And I was just wondering, and this is a long-standing conversation. What does that look like? What do we have to do to change that that future measurement for our CON so that we do take into consideration the safety factors? And you know, I have no idea how to do that, but somehow we should get there. That is our future. Thank you.
So Rachel is saying, Shelley, if you could go back to the presentation. Sure. And then go to slide 21, focusing on kind of some of the agency data conversation.
And Vince, this is Rach. To your question, I think that this is definitely a culture shift. Looking at EMS 2050, the question in all of our minds is, how do you get here? And the text on this slide is quite small, but the authors of this paper, Culture Shift, Reducing Life and Operation, talk about agencies using data to cross-reference patient clinical presentation upon EMS arrival with EMD response priority, and really using the data that agencies have available to determine how response mode may or may not impact patient outcomes. I think this is something really important that we think about and consider. How can quality assurance program help us to ensure safe response modes and the best patient outcomes possible, balanced with those safety risks that we assume when we do use lights and sirens. I don't know, Dr. Bradley, if you have anything to add since you've been a part of different quality assurance initiatives.
It's a tough balancing act, and I think part of this is really finding, number one, making it a priority to look at the data. I think when there is an ambulance crash, we tend to get focused on this and say, okay, this happened, we want to hopefully avoid this, and we may focus on that, and then somebody else comes across our desk and we shift our focus away from that. But recognizing that this is going to continue to be there. And so how do we try to figure out, is there a way to redirect some of our focus and attention on when does it clinically make a difference? So when is it really important for us to send that unit lights, siren to the scene or to transport? And being aware that there's maybe many opportunities to improve that, especially on the transport side of things. So sometimes when you think about dispatch to a scene, you may not have accurate information or great information, and so you have to err on the side of potential patient safety. But once you're on scene and the crew's done this, that's when they start their intervention. Is there an opportunity that may be an easier way to address this first, right? That kind of looking at that transport side of things. Once we're transporting, can we start decreasing the number of lights and sirens transport, because it doesn't necessarily change a patient's outcome, that 2.5 minutes that we spend lights and sirens versus without. So, sometimes try to tackle the part that's a little easier. In my mind, that's probably the easier side of the equation to address. Does that answer your question, Vin?
It does. In my mind, I was thinking, well, maybe this is something that each of our agencies can take a look at our data to see, number one, how we can, go through, determine which cases, which transports really fit that immediate code 3 needs, such as STEMI, stroke, trauma, where you have an immediate intervention somehow. And take a look at those, and then maybe those are the ones that we say, what was your response time on? Just taking a look at that outcome data to say, yep, it meets the criteria and that threshold, and so therefore we're going to do a number or take a look at the response times over a year of these type of cases. And it gets down into the weeds of what is your EPCR able to do? Can your CAD data capture that accurately and correlate it together? There are a lot of questions there, but I, as Guardian Medical Transport, I think we're going to just do a test run to see if we can't look at some outcome cases and see if we can make any, if it leads to anything. We'll be more than willing to share that.
Vince, thank you for your comments. This is Rach again, and I think that what you're describing really sounds a lot like the time critical condition that one of our other work groups outlined, semi-stroke, major trauma. I think we also defined hemodynamically unstable patient as being considered as time critical conditions. And it would be very interesting to look at the data in that regard and see what differences do exist in a quality assurance initiative.
To address a couple of the other questions in the chat, and then I'll come back to the hands raised. Kyle, to your question regarding any white papers or studies looking at going to that, I am not aware of any specifically looking at that question. And then Scott, we are not able to add people to the Bureau's delivery list, but we can certainly share how to sign up for it. So I'm happy to share how to sign up for our Gov delivery. We promise not to spam you. We give you to say judiciously, but you do have to opt in to get the communication automatically. So I will make sure that we put that in the chat so you can sign up for it. Make sure when you do sign up, just select the Bureau of EMS. Otherwise, you can get all ADHS certification. I do see a couple hands raised. I think going in order. It looks like Ben, I think it's Ben potentially.
Yes, that's me. You hear me okay?
Yes.
So I actually had a quick question as far as like the data, and I know it's very hard to see if there's any possible way to look at the matrix of actually how the data was collected. The reason why I'm asking that is transportations can be skewed in so many different areas, and the reason why I'm saying that is it also depends on the location of hospital. right? Because it kind of goes back to what Mr. Martinez was talking about is there's a lot of critical thinking and strategic decision that goes into when you go code 3, when you go to code 2. You could just take Phoenix, for instance. You got South Phoenix that does not have a very close hospital that is 2.5 minutes away. That even going code 2 or code 3 wouldn't matter because it's right down the street. It's not like it's stationed, city of Phoenix, where say you're at 7th Avenue and Camelback and you have St. Joseph's that's right down the street. Going code 2, code 3 really wouldn't make a difference. However, you have other populations or other locations within the city that the hospital and its specialty is at a good distance away. So kind of, I believe, goes the same things as what Mr. Martinez was talking about, is looking at those time sensitive and actually see what that data shows compared to, because I'll tell you one thing, it depends. If you're not the one calling 911, you're going to want lights and sirens. You want us there as quickly as possible and to your doorstep as the most efficient manner. Because you're the one, or your loved one, or your child is having that medical emergency that you deemed as an emergency. And my last thought, and I think would be, is that I would caution as far as, and maybe look at some better suggestions, is allowing a dispatcher to distinguish between code 3 and code 2 responses. The only reason why I say that is, like many of you being in the industry for a very long time, many times things over the phone when you're calling is not exactly what it is when you arrive on scene. So when everybody's calling and in disarray, or in their what they believe is a time sensitive event, it puts the dispatchers at a very disadvantageous position, because they're not getting the total picture of what's actually happening to some of the folks that are calling. Like I said, there's many times that it may be a time sensitive over the phone, then you arrive and it's nowhere near what the person called in as. So having a dispatcher distinguishing code 3 and code 2, I would say probably it would be a very thing that we would really have to step back and look at holistically.
Thank you. I think, certainly this is where each, jurisdiction should look at kind of working with their dispatch center and looking at some of the data that you have. Roy, we'll try you again.
Yes, thank you. I was on a different platform and apparently I couldn't unmute from that one. So now I can. A couple of points I'd like to address. One, and appropriately, the focus is on ambulance driving safety. And ultimately, I think we'll come to a point where we make recommendations on what type of training the emergency medical responder needs to have to be the, quote, ambulance driver, close quote. The one thing that is conspicuously missing in all of the discussion is training these new drivers on appropriate handling of the vehicle during transport to facilitate effective patient care. I think all of us that have spent a lot of years in the back of an ambulance have had experienced drivers who were safe drivers who operated the vehicle in a safe manner, but the unrestrained paramedic in the back is bouncing around like a pinball machine because we never trained them how to drive appropriately to facilitate appropriate patient care. So I would like to see at least some thought process put into that type of training in addition to the safe operation of the vehicle. And secondly, another distinction that needs to be made is ambulance response versus that of the first responder response. And primarily, as I understand this work group, is to concentrate on ambulance response. A number of years ago in my previous incarnation, I did studies on code 3 responses to the scene in systems where there were first responders. And the first responder, by and large, arrives on the scene prior to the ambulance. And with over 500,000 cases, I made the determination that a ambulance response of, I believe it came out to be about 14 minutes, 14 minutes and a few seconds. Anything less than that did not result in the patient arriving at the hospital in any different time frame. So in other words, until there was a 14-minute response or more, there was no delay in getting the patient to definitive care, because it takes on average that amount of time for the patient to be evaluated and appropriate interventions done on the scene prior to transport. And it always seemed a bit puzzling to me why in Arizona, from a regulatory standpoint, we concentrated tremendously on response times and 90% fractal, which we've all heard about throughout these rules meetings, really irrelevant when you're dealing with a first response system, and the ambulance is usually a second responder, and in which case, if they have a response time of 14 minutes or less, it doesn't make any difference in the time the patient arrives at the hospital. So just 2 points that I wanted to make.
Thank you. Corey, I see your hand raised.
Yeah, so I was going to kind of tie in on a couple of things that Roy actually touched on as well. One of them, and I thought this was super interesting. I don't know for sure that this is part of the EVOC cert, because I am not an EVOC instructor, but I think Roy's point is really valid and well taken. We do a ton of driving with our folks in the back of an ambulance during our EVOC certification. I will check it with my driving instructors to see if it's part of the actual EVOC cert or not, but tied to Roy's point, I think that is extremely valuable. And we do that with our folks in the 40-hour EVOC driving class that they get. It's very rare that in our system, at least, that you have an EMT in the back of that ambulance while it's driving down the road. They are normally driving the ambulance. So we give them time so that they can feel what it is to be in the back of that ambulance, trying to provide care, do documentation, all of those things. So it helps them to be better drivers. So I don't know for sure that it's required in the EVOC course, but it is a huge component to the way that we teach EVOC to all of our personnel. And I think it's very valuable as you move through this, that we continue to focus on that so that they understand what we're doing in the back of those ambulances. The other thing, and I think tying into what Ben was talking about, and then what Roy tied onto that as well, is I think from our system in Mesa, we are not looking to change where our risk comfort zone comes in on where we send what we send units code 3 to. And by units, I mean first responding units. What Roy was kind of getting at is the first unit, the closest unit to that medical emergency. If we have built our dispatch protocols, which we work directly with our medical director and our EMS team and our senior staff to decide what those dispatch protocols look like, the closest unit will still continue to respond code 3. That's not going to change. If that won't change in the city of Mesa. That's our we're risk adverse in taking chances, kind of tied to what Ben was getting at, and I think what Roy was tagging on to. Generally speaking, that closest unit will be a fire truck, will be an engine or a ladder with 2 paramedics and 2 EMTs on it. So they will still continue to respond code 3. What I was looking for, and I think where this group was going, is what we have seen in our system is there's room for us to decrease the number of calls that these smaller ambulances that are at a much greater risk of injury or death when they're involved in an accident responds code 3. And I think that that's kind of where this group was leaning into. I think we from Mesa absolutely support that. If that ambulance still continues, is in the situation where it is the closest medical care provider to that call, we are probably still going to send that unit code 3. I know it's a smaller unit. I know there's some risk to that, but there's we do that analysis, right, of the risk versus benefit. But in the overall scheme, I love the idea of larger apparatus that give our folks a lot more protection, being those units that are primarily responding code 3 to these calls that we've identified as high risk and high benefit to get EMTs and medics there, and the ambulances having the opportunity to have a little bit of a slower, a longer response time because I've got medical professionals there and on scene. So I like this, and I like the work that you guys are doing to move us in this direction.
Shara, I see your hand up.
Yeah, just as an aside, I don't know if you had mentioned this previously because I missed the first couple slides. There was a study in Annals in like 2019 that split apart response accident adjusted risks, odds ratio risks versus transport. And obviously substantially it was 3 times as much for transport. So, you know, hearing what everybody's saying with, you know, their departments and risk aversion, you know, I think that, you know, if you're looking at moving the group towards something, you'll have much better, sounds like responsiveness, at least working on the transport area to the hospitals quicker than, you know, working on EMD. And at some point I see in the future us moving it, how do we get better EMD to minimize non-emergency response to these calls? But I think the lower hanging fruit is the transport phase to the hospital.
Yeah, absolutely. Thank you, Shari. Roy, I see your hand up again.
Yeah, this is just to follow up with comments made by Corey. I am a EVOC instructor, and it was not part of the EVOC curriculum to train the personnel on actual transport driving to facilitate interventional techniques and appropriate treatment of the patient. I always found that quite lacking because that was always seemingly the place, as was pointed out by Shari, that we had the most accidents. And so that's a critical component that was missing, is my opinion, from EVOC, and one that we added in as sort of an addendum to EVOC. And that was a high concentration in the training phase, which it sounds like it is for Corey as well, where you actually have them out there driving and put the EMT in the back and have someone drive appropriately and inappropriately and show them the difference. So it's just it's something that is missing from the pure safety discussion. It's safety plus efficacious environment for treatment of the patient.
Thank you. So I do see Shelley's in the chat how to sign up for our communication features as well. And, you know, definitely we've had really good discussion. I wanted to go back to a couple of the questions that the group had put forward initially to bring back to this meeting, which was number one, to get some feedback regarding the training for EMR, both the medical component as well as the driver's training component. And then also any thoughts or recommendations regarding public safety messaging. So can I get feedback first if anyone has anything they'd like to share regarding the EMR component?
I'll say something.
Everybody in the room.
Maybe that other people want to. I've heard a lot about how much time you spend doing the training for this. And I think we need to focus on the content of that training. And my reason for that is you're going to spend a lot more time in a metropolitan area where you have 10 to 25 people in a class, as opposed to in a real rural area where you have 1 or 2 people in a class to cover the same material. So I think we need to focus on content instead of hours, if that makes sense. And for instance, you spoke about ride-alongs when you were an EMT. Well, in Phoenix area, you could get 5 ride-alongs in 1 or 2 shifts. In a rural area, you may have 10 shifts to get to that. So that's why I think it should be that way.
I wasn't specific, actually, the clinical experience in the hospital based.
Okay.
Training. So in the recommendation, it's that you have some type of clinical interaction. But it doesn't specify.
I agree with you there, and I think probably it needs to be a certain number of actual trips as opposed to how many hours you spend, because you may spend all those hours sitting in quarters doing nothing.
Any other feedback from anyone else in the group?
A quick question.
Yes.
I know last time there was a lot of discussion about EMR and EMD training. Did we find information about any of those training programs in the state?
EMR or EMD? Well, there are some current EMR training programs. There is quite a bit that TJ can speak to that probably could take several hours with separate to this conversation. As part of the rule update process, the Bureau and Department does need to create a standard for EMR for the state of Arizona, and so looking to get some feedback regarding that. In regards to EMD, that's a little bit different because EMD is really a specific type of dispatch. So there are many other dispatch systems that dispatch centers across the state of Arizona use. So EMD is a type of dispatch, but there's other different dispatch models that are still doing patient screening. So we tend to use EMD as a general descriptor, but it's actually a specific type of a brand per se. I guess maybe not that term, but we didn't put that away to describe that.
Yeah, I'm just wondering if any of that would be adopted into our future certifications or credentialing or.
And just a quick reminder on some of those comments piggybacking. We talked about this last work group, and I just want to remind folks, our certification and training rules are up for the 5-year review. Certainly, we're in that process of looking at the existing certification and training rules. And just as covered today, some of the new laws go into effect in January definitely require that we look at prioritizing, updating certification and training rules. That would include emergency medical responder training and certification standards. And I think I stepped over somebody in the room. Jim, did you have a comment?
Oh, I've enjoyed the slides. Could we get a copy of them?
Yes, we will share them.
Okay, thanks.
Yes, we will share the slides that later on today. To your question, we do not have another meeting on the agenda. I think the question was, do we need to have another meeting on the agenda? The goal was to really kind of bring this back to this group, have some discussion. There will be more discussion on this in regards to some of the EMR standards and recommendations of education and PMD in November. And then, definitely is one of the things that will come forward at EMS Council in January, which will be the third Thursday in January. I don't know the date off the top of my head, where EMS Council will get a follow-up for this group.
Yeah, listen, TJ, I can touch on a couple of those points if you wanted me to real quick. We have at one point had 19 different programs that were providing EMR training in Arizona. We never had a certification, but those students were able to get cleared to take national registry. We currently have 150 nationally registry certified individuals who hold the EMR cert in Arizona today. To the point about the vehicular and clinical training, there's actually 3 options with those. All of our programs are based in hours, so it matches with the timelines that we have for the paramedic program, the AEMT, EMT program. So the EMR was set up to match that, and the hours dedicated to clinicals, vehiculars, can also include high fidelity simulations, and that addresses the issue with those areas that aren't going to run as many calls. So you can set up in the classroom to simulate a call and have those count as well.
Did he say we currently have a curriculum? That's what I thought I heard him saying when I asked for one. I was told it didn't exist.
There's not an official state of Arizona one. There is a national standard. And again, all of our rules point to programs following the national standard. So a student has to complete a program that meets or exceeds the national standards that have been established for that level to be eligible to take National Registry certification. So there is one, we just don't have an adopted one for the state other than pointing to the national standards.
Just for my clarification, where would you find that?
EMS.gov has a number of different documentation that's been put out by NHTSA, and they have the documents relating to training standards, scope of practice, and a number of other resources that are available for download.
Thanks.
In this presentation, there are hyperlinks to several to those documents. So we're going to scope of practice on some of those educational standards. So when this goes out, there should be the hyperlink that should take you to those documents as well. I see one more question in the chat regarding some safety messaging and possibly a PSA. Understanding that we do have the November crash safety week coming up. Shelley, did you maybe go to the last slide of a presentation? Sure. These were borrowed from the internet, so I do not have any copyright permission to be sharing these per se, although I don't know that any of them are necessarily copyrighted, but certainly wanted to look and see, what the group's thoughts are of potentially getting some messaging out there. I think definitely within the PIO here at the department, along with many of our other municipalities, how do we get this messaging out there? David, I see your hand raised.
Yeah, the Arizona TIM Coalition, which oversees CRSW for Arizona's contribution, we're working on some standard PSAs through each of the public information officers for the lead state agencies. We're waiting to get feedback on what that press release looks like. If we're going to be able to do one for each of the 5 themes that week. If you want to have someone email me, I'd be happy to provide some information on CRSW, the flyers, and other stuff that Federal Highway has put out. I can also add it to the shared drive in the meantime for us to use, like Shelley and Gail to review.
Thank you, Dave. This is Rach, and I know that, I think it's slide 24, Shelley. The federal website, remind me, Dave, it's NHTSA or is it FEMA? We have the link in here. If you click on these, there is a toolkit with messaging for every day, since every day does have a theme, starting with protect those who protect you. Certainly we can share the slide with the federal toolkit that has been developed. And for additional messaging, we're fortunate to have Dr. Dave Harden on the team because he can help share some of the state messaging as well.
Yeah, that's Federal Highway Administration. Yeah, so feel free if you want to coordinate what you want to put out. I'd be happy to, be of any value to put you in touch with the chair of the TIM Coalition, see how we can facilitate that for you. At least be a part of what you want to do. So you're free to do what you want. If you want to do a special on your own, by all means, we encourage individual participation. But if you want more information, feel free to get back to me.
And Roy, I did see your hand raised. Roy, go ahead.
This may be a question for TJ. A couple of my clients have expressed concern about, not concerned about the state developing a curriculum, but requiring the NREMT EMR certification as a certification for Arizona, because it's my understanding, at least what they've informed me, that it has an exorbitantly high failure rate. And in fact, it's much more difficult in some cases for individuals to get that certification it is to get an EMT or paramedic cert. So do you know what the failure rate is, TJ, on the EMR certification?
I do. And actually, our State Department of Education put out a curriculum as well that wasn't in consult with the Bureau. So they've got some items there we can also look at. But as far as the state goes with Arizona programs, who were the clearing bodies for the National Registry test, overall, we're running currently at about a 41.51%, and that's today. Historically, though, going over the last probably 13 plus years, we're at about 56% on the first time attempts and 63% for the cumulative attempts. But one of the items that I would suggest as a variable on those is none of those programs are regulated in any way, shape, or form. So we're not going in and looking to see what type of education they're providing, what the qualification of the instructors are, involvement of medical direction, or any of those other things that we do monitor with our regulated programs. And just to contrast those, you've got about a 30-point difference on the regulated programs versus the unregulated on first-time attempts, and it's better than half the success rate on the unregulated programs versus the regulated on the cumulative attempts. So it goes from about a 41.5 on the first and cumulative for EMRs to a 75.3 for EMT and paramedic on the initial, and then an 85.3 on the cumulative attempts. So we're not exactly comparing apples to apples, just based on the fact that there isn't really any oversight on those existing EMR programs that are operating within the state, and only 10 of those that have cleared anyone actually has an approved Arizona training center to go along with their EMR training. But we don't look at those specific programs, even if they do have a state of Arizona approved training center.
Thank you.
Thank you, TJ. Into the last question, these are not it's the ADHS approved pictures or messaging. Yes, these are just an example, but we wanted to get some feedback from this group on. I see one vote for, if you see the light move to the right, so that was my personal favorite as well. But just really trying to get feedback from the group. I think this is definitely an opportunity that I don't know that we've spent on messaging previously from the Bureau or ADHS. We certainly do for many other celebrations and important messaging, and this is an opportunity that we can as well. Yes, David?
All right, I put in the chat the link to the virtual TEM class during Crash Responder Safety Week, November 16th. It's from 9 to 1 p.m., 4 hours, and it's CAPCI approved for CEs. And there's a link you can sign up to register for that. If you want to pass it around and make it part of your training for that week, that would be great. Thank you.
Thank you. Are there any further questions or comments? Otherwise, I don't like to keep the meeting going just for the sake of keeping the meeting going, but I think we had really good discussion and we appreciate the feedback, and we will definitely be bringing more of this conversation at our upcoming standing and statutory committee meetings. We appreciate everyone's participation, both virtually and in person today, and I look for the slides to come out later today. And if you're not yet signed up for our Gov Delivery Communications, that link is in the chat. You can go ahead and sign up, and you can get the communications from the Bureau as well. All right, not hearing anything else, we will go ahead and adjourn. Thank you, everyone.
Thank you.
Bradley. Thank you, everyone.